Diabetes is a group of metabolic disorders sharing the common underlying feature of hyperglycemia. Right? So mainly there is hyperglycemia. This is the diabetes is the people who have got diabetes, they feel that they don't feel anything. So they think that it is something which is not. I'm a little new at this Zoom, so please bear with me. Achha. The people who have got diabetes, they feel that they don't feel anything. So they think that nothing is wrong. But this disease is, it's like a termite, it's like a demon, eating away the things and causing many metabolic abnormalities. And because of the metabolic abnormalities, many complications of diabetes will be occurring, like myocardial infarction, stroke, retinal damage, kidney damage. Many things can be are because of this diabetes. Now, the hyperglycemia, which is produced in these patients, can be due to decreased insulin secretion, defective insulin action, or both. Right? If you have any questions, you can just, where is the, you can ask me, I don't know if you can do it. All right. Now, something which is called prediabetes. Prediabetes is defined as elevated blood glucose that does not reach the criterion for diabetes. These people have an elevated risk of developing diabetes. They are not really, when I will go to the diagnosis of diabetes, you will find out that if they have, there is a gray area between a normal patient and a diabetic patient. So between that and the gray area, there is a something which is called prediabetes. And these people have an elevated risk of developing diabetes. Okay. The diagnosis, usually what happens in our body, people who are normal, their blood glucose remains usually in the range of 70 to 120 milligram per deciliter. How do you diagnose diabetes? Diabetes can be diagnosed by many criteria for the diagnosis of diabetes. A fasting glucose concentration greater than or equal to 126 milligram per deciliter on more than one occasion, right? Now the value of this is 126, greater than or equal to 126 milligram per deciliter if the patient is fasting, at least 8 hours fasting. Then if it is greater than 126, the patient is considered to be a diabetic. Or random glucose concentration. These are the criteria for diabetes, but you should have two values. Anyone, if they take a fasting glucose, then with that you do an HbA1c or fasting glucose on 2 occasions. Two of the criteria should be there. It should be done twice to diagnose diabetes. Right? Only one value is not enough to diagnose a person as diabetic. Why? Because the glucose, the hyperglycemia can be caused by many other problems also, like some stress, some infection, some other thing which can cause diabetes. Nowadays, everyone life is very stressful. With this COVID also, there are certain stresses, everyone has got stress. So, if supposing you get a fasting glucose in the diabetic range, you should do it again. After 15 days, after removal of the stress, and then see that if still the glucose remains the same, then you label the person as a diabetic. Random glucose concentration greater than or equal to 200 milligram per deciliter with the classic signs and symptoms of diabetes. The signs and symptoms of diabetes we will be discussing in the next lecture. Random glucose means a glucose of after 1.5 to 2 hours after breakfast is called a random glucose. Random doesn't mean do it anytime, right? A random glucose means 1.5 to 2 hours after meals, preferably after breakfast, right? Okay. Then we have an abnormal oral glucose tolerance test. OGTT is called an oral glucose tolerance test. I think you must be knowing how it is done. A patient comes to you fasting. Take the blood glucose of the patient, the fasting sample for blood glucose, then give the patient 75 grams of glucose to drink in a glass of water over a period of 5 minutes. After the 5 minutes are up, you note the time, and 2 hours after that time, you take another sample for blood glucose, and this is the OGTT is done. Now, 2 hours after the glucose load. If the blood glucose is greater than or equal to 200 milligram per deciliter, then the patient is labeled as a diabetic. Oral glucose tolerance test can be considered to be a confirmatory test or a standard test for diabetes. One test or one OGTT also is good enough, but you don't do an OGTT. If you just suspect someone for having diabetes, you don't go directly for an OGTT. You go for a fasting glucose or a random glucose. So, but if you do an OGTT, that is considered to be a diagnostic test for diabetes. Then HbA1c greater than or equal to 6.5%. HbA1c is like glycosylated hemoglobin. This is the hemoglobin attaches to the globin of the hemoglobin, and as the life of the RBC is 120 days, this glucose attached to the hemoglobin of the RBC that gives the glycemic control over the previous 3 months. Okay? So it is better HbA1c. The advantages of HbA1c are that you don't need fasting, and secondly, you have know the glucose status of the patient of previous 3 months. Because sometimes these people, these diabetics, they are very clever. What they do is they want to go for a blood test in the morning. In the night, they don't have much food. They fast or have very little food, and then they go for the glucose, and their fasting glucose comes out to be normal. But the पीछे का जो वो होता है ना, तो सब चिट्ठा उनका बाहर आ जाता है when they go for an HbA1c. Then you find out that yes, so all the 3 months the patient has been binge eating, been having lots of sweets, and then now this one day he has stopped eating and the fasting glucose is normal. So HbA1c gives the previous whatever the patient has done over the past 3 months, get your properly. Now, what thing is, out of these 4 criteria, any 2 criteria, if you get it, then you label the person as a diabetic. Or fasting glucose on 2 occasions, or you can do a random with the classic signs and symptoms is also 2 things. OGTT is a diagnostic test. You can do 1 OGTT and you will. Or if there is a fasting glucose, along with that you do an HbA1c. So any 2 of these criteria you use for the diagnosis of diabetes. Patients with a fasting glucose less than 100. If the fasting glucose is less than 100 or the 2-hour glucose is less than 140, the patient is considered to be normal. So now you know that there is a gray zone. Less than 100 is normal. 126 is diabetic. So 100 to 126 is a gray zone. Similarly, 2-hour glucose, 140 is normal, 200 is diabetic. So 140 to 200 is again a gray zone, right? So what will you do in that gray zone? There is something which is called prediabetes or impaired glucose. Now prediabetes has got 2 things. One is impaired glucose tolerance and one is called impaired fasting glucose, right? So impaired glucose tolerance is what? That patients have a normal fasting glucose. The 2-hour post-load plasma glucose, that is OGTT, 2-hour OGTT glucose is between 140 to 199 milligram per day. So the gray zone in the 2-hour, 140 to 199, that is considered impaired glucose tolerance. And OGTT is required for its diagnosis. HbA1c can be between 5.7 to 6.4%. So these glucose values, you should know them. You will not, in the exam, you may not get the reference values for this because this is very important. You should, for diabetes, you should know what the glucose 126 for fasting, 200 for diabetic. You should know these. And to know this, to remember these, the most easier way is you learn the values of pre-diabetes. You learn this value OGTT 140 to 199. You learn the value 100 to 126. You learn the value 5.7 to 6.4. When you learn these pre-diabetes values, you will remember the normal values, you will remember the diabetic values. Okay. Impaired fasting glucose. In this, what happens is the 2-hour glucose is normal, but the fasting glucose is between 100 to 126 milligram per dl. So this patient is called an impaired fasting glucose. Impaired fasting glucose and impaired glucose tolerance are both parts of prediabetes. ठीक है, if anyone has a question, you can please ask me. I don't know how to go about it, but you can. I think you're not muted. You have muted yourself. So when you can unmute and you can ask me any question you want at any time. Acha. So if the patient has got an impaired fasting glucose and the patient has got an impaired glucose tolerance, that is 2-hour glucose is also impaired, then then you call the patient as an impaired glucose tolerance. Okay, not an impaired fasting glucose. Impaired fasting glucose is just in one condition in which the 2-hour glucose is normal, but the fasting glucose is impaired. Then you call it impaired fasting. Okay. Now, both these conditions, impaired fasting glucose and impaired glucose tolerance, they are not clinical entities, but they are risk factors for diabetes and cardiovascular disease. These patients, they may develop diabetes later in life. These patients may develop, usually these patients, they do not develop the microvascular abnormalities, but they develop the macrovascular abnormalities. We will do this when we do the complications of diabetes in our next lecture. But for now, you must just know that the macrovascular complications of diabetes, like the cardiovascular diseases, myocardial infarction, stroke, all these diseases, the patients of pre-diabetes can have these diseases. The risk of complications increases and the risk of development of diabetes increases. These patients are not called diabetic, but you have to be careful about them. We have done. Now, classification of diabetes. In your book, there is a huge classification. It's quite complicated one, but this is how we have studied this, and it's a much easier way to remember. It's the same, but it's a different way. Type 1 diabetes, type 2 diabetes. Then the third one is other specific types of diabetes, and in the fourth one, we have got gestational diabetes. Right? In the other specific types of diabetes, we have genetic defects of beta cell function, genetic defects of insulin action, endocrinopathies, drugs, exocrine pancreas disease, infections, and genetic syndromes associated with diabetes. Right? And then there is gestational diabetes. Type 1, it is an autoimmune disease due to pancreatic beta cell destruction and absolute deficiency of insulin. Most common type in patients less than 20 years of age. Now here there is autoimmune destruction. Beta cells are not working. You know that the pancreas has got beta cells in the islet Langerhans which produce insulin. So there is insulin is deficient and most of the people are less than 20 years of age. It is caused by a combination of peripheral resistance. Type 2 diabetes is caused by a combination of peripheral resistance to insulin and decreased secretion by the beta. So there is resistance, two things. There is resistance, and there is decreased secretion of the beta cells. We will do this when we do the pathogenesis. I will explain to you in detail. Most of the patients of diabetics, you will be knowing. I'm sure many of you have a relative in the family having diabetes. Some of your parents may be having, or your grandparents, they will be having diabetes. So it's very common, especially in the Indo-Pak subcontinent. 90 to 95% of diabetics are type 2 diabetics, is mostly adult onset and associated with obesity. Now, to understand the pathogenesis of diabetes, you should know how normal glucose homeostasis happens. Normal glucose homeostasis is tightly regulated by three interrelated processes. Glucose production in the liver, glucose uptake and utilization by peripheral tissues, mainly the skeletal muscle, actions of insulin and counter-regulatory hormones, including glucagon or glucose uptake and metabolism. So, the liver, the peripheral tissue, that is mainly the skeletal muscle, and the counter-regulatory insulin and the counter-regulatory hormones. Insulin and glucagon have opposite effects on glucose. Now, what insulin does basically is that insulin causes the entry of glucose into the cells. When there is entry of glucose into the cells, that glucose can be used for energy by glycolysis, or that glucose can be stored in the form of glycogen. Right? So two things occur. Main thing what it does, it causes the entry of glucose into the cells. If insulin is not there, glucose cannot enter into the cells. So during fasting states, when the blood glucose is low, insulin levels are also low, glucagon is high. And because of this, because of low insulin, The glucose cannot enter into the cells for the formation of glycogen. When glycogen is not there, there is gluconeogenesis. The liver starts making glucose from fats, from amino acids. There is gluconeogenesis. So that starts, and glycogenolysis. The glycogen starts to break down into glucose because you need glucose in the body. So glucose is produced from amino acids or fats, or glucose is produced from the glycogen. And so hypoglycemia is driven. When you fast, when you're during a fast, from the morning till afternoon, you feel your glucose goes low. So all these, there's glycogenolysis, there is gluconeogenesis, and because of this, the glucose level comes up and hypoglycemia is prevented. Thus, fasting plasma glucose levels are determined mainly by hepatic glucose output. Now, after a meal, what happens? The blood glucose levels rise, insulin levels rise. Now, because of the insulin causes the entry of glucose into the cells, right? The glucose enters into the cells, mainly the liver and the skeletal muscle. These are the main, and the adipose also, but liver and skeletal muscles are the main areas where the glucose enters. Skeletal muscle, what does it do? It makes, either it uses the glucose for energy, or it converts the glucose into glycogen and it stores it. And so the hyperglycemia, the blood glucose level falls. Hyperglycemia is prevented. This is for a normal person. Regulation of insulin release. Now, when insulin is released, it is released in the form of pre-proinsulin. It is a larger molecule, pre-proinsulin it is called. It is synthesized in the rough endoplasmic reticulum of the beta cells of the iris of Langerhans. Now, this insulin, pre-proinsulin, large insulin molecule is broken down. It is cut, it is broken down by proteolysis to form one molecule is insulin and one molecule is called a C-peptide. The importance of C-peptide is that you know that this insulin is being secreted, they are secreted at equimolar concentrations. One molecule of insulin which is secreted, it will secrete one molecule of C-peptide. So you find out they are secreted equimolar concentrations. So this is useful when in the case of when we do the complications. I will talk to you about this. That when supposing the patient goes in hypoglycemia, you don't know whether the person has taken excess exogenous insulin from outside, or the patient is making excess insulin. So at that time, you measure the C-peptide. If you find out that insulin is raised in the patient and C-peptide is also raised, that means the person is making that insulin. And if the C-peptide is low and insulin is high, that means the patient has not made this insulin, the patient has taken this insulin from outside. So that is the role of C-peptide. How the reason you test the C-peptide. C-peptide levels are reduced in type 1 diabetes mellitus and increased in insulin resistance associated hyperinsulinemia. If in type 2 diabetes, I will talk to you in, subsequently, that in type 2 diabetes there is hyperinsulinemia. So in that case, C-peptide will be higher. In type 1 diabetes, there is hypoinsulinemia. Less insulin is produced, so C-peptide level will be low. The most important stimulus for insulin synthesis and release is glucose itself. When blood glucose rises, it causes release of insulin. When blood glucose falls, it causes decreased insulin. A rise in blood glucose results in glucose uptake into pancreatic beta cells, facilitated by insulin-dependent glucose transport. These are GLUT. There are many GLUTs, GLUT 2, 3, 4, like that. GLUT is GLU is glucose, T is transport. Glucose transporter 2. Okay? This glucose transporter 2 is present in the pancreatic cells and the beta cells of the pancreas. So, because of this GLUT2, glucose enters into the beta cells. Because of the entry of glucose, there is calcium influx into the cells. Then there is a whole process of tyrosine kinase and all the things, a lot of detail. We don't need to go into that much detail. Because of this, there is an immediate release of insulin. There is some stored insulin is present. Because of the glucose entry, calcium entry, this stored insulin is released. Okay? Then if the glucose stimulus persists, then what will happen? There is a secretory stimulus persists, there is a active synthesis of insulin. Then the insulin synthesis also starts and starts getting reduced. Okay. Now the actions of insulin. Insulin is the most potent anabolic hormone known. It is an anabolic hormone. Anabolic Metabolism is catabolism and anabolism. Anabolism means growth, formation, right? So this is a potent anabolic hormone known with multiple synthetic and growth promoting effects. Its main metabolic function is to increase the rate of glucose transport into certain cells in the body, thus providing an increased source of energy. I told you that it causes glucose transport into the cells of the body, used for energy and used for formation of glycogen. Which cells glucose enters into? Mainly the striated muscle, including the myocardial cells, and to a lesser extent the adipocytes. Mainly it is a muscle, also the liver, where the glucose enters and the glucose does its work. Glucose uptake in other peripheral tissues, notably the brain, is insulin independent. One you should know this, that God has made it such that you don't need insulin for glucose entry into the brain. So supposing the glucose levels are very low or the receptors are not there or any problem is there, the brain gets the insulin, so it gets the glucose for its energy. Brain does not use fats, does not use other things, it uses just glucose for energy, and it does, and it can take up glucose even without insulin. In muscle, glucose is either stored as glycogen or oxidized to generate ATP. We have done this before. In adipose tissue, glucose is stored as lipid. Insulin also inhibits lipid degradation in the adipocytes. Okay? Glycogen formation it does. It inhibits lipid degradation, so lipid formation also it does. Insulin promotes amino acid uptake and protein synthesis, and also inhibits protein degradation. It causes protein synthesis. What it does? It causes glycogen synthesis, it causes protein synthesis, it causes fat synthesis. So it causes anabolism of all of these. Okay? Anabolic effects, increased synthesis and reduced degradation of glycogen, lipids, and proteins. Okay? So anabolism of all of these. Mechanism of action of insulin. The insulin receptor, it is a tetrameric protein composed of 2 alpha and 2 beta subunits. Insulin binds to the receptors and causes glucose transporter protein, now GLUT4. Now here in the skeletal muscles, in the adipose tissue, there is GLUT4. In pancreas, there is GLUT2. Here it attaches to, causes the GLUT4 to attach to the plasma membrane, which promotes glucose uptake. See, this is the insulin receptor. These are insulin receptors, the tetrameric insulin receptors. Insulin comes from the blood and attaches to the receptor. This receptor is activated. All certain processes occur, the tyrosine kinase and all those things occur over here. This GLUT4 is present in the cytoplasm. Because of the entry of attachment of glucose to the receptor, this GLUT4 comes and attaches to the plasma membrane. When it attaches to the plasma membrane, the glucose from the blood enters through this glucose transporter into the cell, and when it enters into the cell, there is glucose oxidation for energy, there is glucose formation into glycogen inside the cell. Okay, I hope everything is clear till now. If you have any questions, please unmute your phones and ask me. I'll wait for 2 minutes. Anyone? No? Okay, now we come to pathogenesis of type 1 diabetes mellitus. Type 1 diabetes is an autoimmune disease in which islet destruction is caused primarily by immune effector cells reacting against endogenous beta cell antigens. Now this is an autoimmune, type 1 diabetes is an autoimmune disease. Okay? Why? Previously type 1 diabetes used to be called juvenile onset diabetes, or it used to be called insulin dependent diabetes, but now these terms are not used. Why? Because type 1 diabetes can also occur in the older patients. In the younger people, type 2 diabetes can also occur. Type 1 diabetes requires insulin for survival. Some of the people of type 2 patients of type 2 diabetes also require insulin for survival. So that's why you don't call it insulin dependent diabetes also. But we just call it type 1. Type 1 diabetes, but most of the people, most of the patients of type 1 diabetes, type 1 diabetes develops in childhood, manifests in puberty, and progresses with age. Most of them it is like this, but sometimes there are exceptions to the rule. That's why you don't call it juvenile onset diabetes, you don't call it insulin dependent diabetes. Okay. The now type 1 diabetes basically is that mainly here what happens is that type 1 diabetes, usually the onset of type 1 diabetes is quite abrupt. They are young people, they don't know that they have got diabetes, and all of a sudden they develop diabetic ketoacidosis, very common. The patient develops diabetic ketoacidosis, comes to the emergency room, and then you find out that the patient had diabetes. So the onset appears to be abrupt, but the destruction of the beta cells occurs very early in life. The slowly and gradually the beta cells start getting destroyed. The patient, the remaining beta cells which are good, which are working, they do hyperactivity and they maintain the blood glucose. Then at some point when about 90% of the beta cells are destroyed, at that time the patient shows the symptoms of diabetes. Okay? So when the patient develops diabetes, when the patient shows the symptoms of diabetes, hyperglycemia or diabetic ketoacidosis, most of the beta cells are already destroyed. Okay? The pathogenesis of type 1 diabetes involves genetic susceptibility and environmental factors. There is a genetic basis for type 1 diabetes mellitus. The most important locus for type 1 diabetes mellitus is thought to be the HLA locus on chromosome 6p21. Most of the Caucasians with this disease have HLA-DR3 or HLA-DR4 haplotype. Environmental factors, we don't know much about the environmental factors causing type 1 diabetes. So it is thought that certain viral infections may be involved in triggering islet cell destruction in type 1 diabetes. There is something which is called molecular mimicry. What is that? Is that certain vitamins, certain viruses, they may share epitopes with the islet antigens. The antigens of the virus and the antigens of the islet cells may be similar. So when the body develops an immune response against the virus, that antibody starts acting on the beta cells also, because they are similar. And this is called molecular mimicry. Thought to be one of the reasons, not very clear still. But again, certain infections are also known to be protective against type 1 diabetes. So much is not known about the environmental factors causing type 1 diabetes. Now, how do the beta cells get destroyed? I discussed this before. The autoimmune process starts many years before the disease becomes evident, with progressive loss of insulin reserves over time. When the patient has got the antibodies, the beta cells start getting destroyed. Slowly and gradually, they start getting destroyed. Other beta cells which are working, they do the overactivity, they prevent the hyperglycemia. Then, as more and more of the beta cells are destroyed by the antibodies, the patient develops the classical manifestations of hyperglycemia, ketoacidosis, and this occurs when more than 90% of the beta cells have been destroyed. So most of the type 1 diabetics, when they come to attention, these beta cells are already gone. This is a picture showing you the normal beta cells over here. The blue ones are the normal beta cells, and this is the type 1 diabetic beta cells all destroyed. The main immune abnormality is the failure of self-tolerance in T cells specific for islet antigen. So there is a self-tolerance of T cells is not there. Now the islet autoantigens that are the targets of immune attack may include insulin itself. Now there are certain antibodies which are produced, like antibodies to insulin, antibodies to anti-GAD antibodies, beta cell enzyme glutamic acid decarboxylase. There are antibodies to that enzyme, anti-GAD antibodies they are called. Then there are ICA 512, islet cell autoantigen antibodies to the islet cell autoantigen 512 are present. There are about 5 or 6 different types of antibodies which are seen in these patients. So the most common is the antibodies against the islet antigen. They are present in most of the cases of type 1 diabetes mellitus, also in their asymptomatic family members who do not have diabetes at the moment, but they have these antibodies and they are at a risk for development of diabetes. The presence of islet cell antibodies is used as a predictive marker of the disease. The pathogenesis of type 2 diabetes mellitus, it is a multifactorial complex disease. Genetic factors have been suggested, but here the genetic factors have a greater role in type 2 diabetes as compared to type 1. Environmental risk factors, obesity, Obesity also, the central or the visceral obesity, is more of a risk factor in diabetes. Sedentary lifestyle independent of obesity. Now, both of these things nowadays, this was called adult onset diabetes, right? But nowadays, because of the sedentary lifestyle and the poor eating habits, we have got a diabetes epidemic in our country also and the world, in which there is these young people, all of you, even my children, they love junk food, burgers, drinks, fries, all these things, right? Lifestyle has become sedentary. We are all sitting on the computer and the whole day doing nothing. So the sedentary lifestyles and obesity, these things have developed something which is called a diabetes epidemic in the world, right? And these are the risk factors, environmental risk factors for diabetes. And we have seen that in case of type 2 diabetes, if there is mild type 2 diabetes, the first step in their management is that you tell the patient to start exercise and you tell the patient to lose weight. Many of the patients with mild disease, just with losing weight and just with exercise, they maintain their blood glucose. They don't need any medicine for it. So this is a very important risk factor which can be easily prevented. Okay. Type 2 diabetes was previously called adult onset diabetes, but nowadays we have seen that even in young adults, type 2 diabetes can occur again because of this sedentary lifestyle, poor eating. Metabolic defects in type 2 diabetes mellitus. There is no evidence of an autoimmune disease. There is no autoimmunity which is involved. The two metabolic defects are insulin resistance and beta cell dysfunction. Insulin resistance is defined as the failure of target tissues to respond normally to insulin. Insulin is there, but the target tissues cannot respond to the insulin. Mainly affects the liver, skeletal muscle, and the adipose tissue. These are the three main areas where the glucose is utilized and all the things after the liver, the skeletal muscle, and the adipose. Insulin resistance results in OETs. Insulin, the work of insulin is not done or done less. So what happens? There is less insulin which is worked. There is failure to inhibit endogenous glucose production, gluconeogenesis in the liver. We did this because of low insulin, gluconeogenesis occurs. So when there is insulin resistance also, gluconeogenesis occurs. Failure of uptake and glycogen synthesis in the skeletal muscles after meals. After you take a meal, this glucose does not go into the cells for glycolysis, it does not go into the cells for glycogen formation, so glucose accumulates in the blood. Failure to inhibit lipoprotein lipase in the adipose tissue, leading to excess circulating free fatty acids, which increase the state of insulin resistance. Okay? This is an enzyme, lipoprotein lipase. It is not inhibited due to lack of insulin activity. There is increased circulating free fatty acids, which causes insulin resistance. We will do this later. See, these are the two cells. This is a normal cell having all the insulin receptors working properly. So all the glucose insulin attaches to the receptor and glucose enters into the cell. Where in the case of this insulin resistant cell, just two receptors are working. So less glucose enters into the cell and more of this glucose accumulates in the blood and causes hyperglycemia. Insulin resistance and obesity. Obesity is the most important factor causing insulin resistance. The risk for diabetes increases as the body mass index improves. It is not the absolute amount, but the distribution of body fat. I told you that central or visceral obesity is more likely to cause diabetes than fat. Now, how does obesity affect insulin sensitivity? First is free fatty acids. There is an inverse correlation between fasting plasma free fatty acids and insulin sensitivity. More the free fatty acids, less the insulin sensitivity, more the insulin resistance. Adipokines. Adipose tissue also is a storehouse for fats, but it is also a endocrine organ that secretes hormones. The hormones which are produced by the adipose tissue are called adipokines. There are certain pro-hyperglycemic adipokines, like resistin and retinol binding protein 4. There are certain anti-hyperglycemic adipokines like leptin and adiponectin. Here, which adipokines are important for you are these two, leptin and adiponectin. Both of these improve insulin sensitivity. When a patient is obese, the levels of adiponectin and leptin are reduced, causing insulin resistance. Now, what happens over here is, I'll have to finish this. Inflammation. This has emerged as an important factor in the pathogenesis of type 2 diabetes mellitus. Pro-inflammatory cytokines secreted in response to excess free fatty acids and glucose results in insulin resistance and beta cell dysfunction. The inflammation also causes type 2 diabetes. Now, what happens is in type 2 diabetes mellitus, there is insulin resistance. So, insulin secretion is initially higher for each level of glucose than in the control. So, initially what happens is there is insulin resistance. So, beta cells hyperactivate, do the hyperactivity to bring the glucose to normal. Right? So, we have seen that many of the obese people, obesity causes insulin resistance. Right? Many of the obese people are not diabetic. So, that means insulin resistance is not the main factor for causing diabetes. Right? So these people, because of insulin resistance, their beta cells hyperfunction, they increase their activity and they maintain the blood glucose level. And if you check the blood glucose, check the blood insulin levels, you find increased insulin levels in these. There is hyperinsulinemia to compensate for the blood glucose, and it can maintain the blood glucose for many years. Okay? Then comes a time when the blood glucose, the beta cells, they become fatigued, tired, destroyed, and now the beta cells cannot hyperactivate. The hyperactivity of the beta cells is not there. Beta cells start getting destroyed. When they start getting destroyed, then there is beta cell activity is reduced, the beta cell function is reduced, then diabetes happens. So if someone asks you that insulin resistance is the cause of type 2 diabetes or beta cell dysfunction is the cause of type 2 diabetes, it is the beta cell dysfunction which is the cause of type 2 diabetes. Okay? Remember that. Several mechanisms are there. Excess free fatty acids that compromise beta cell function and attenuate insulin release, lipotoxicity, impact of chronic hyperglycemia, abnormal incretin effect, myeloid deposition within the ILS, impact of genetics. All these factors cause beta cell dysfunction. Okay, now one small point topic we will discuss here, gestational diabetes mellitus. I hope you have understood all the things. If there is any query, please ask me about the pathogenesis of diabetes. Any question, please unmute your mics and ask me. No? Okay, now we come to gestational diabetes mellitus. 5 more minutes of your time. Gestational diabetes mellitus is defined as carbohydrate intolerance of variable severity with onset or first recognition during pregnancy. Not much detail has been given in your book about gestational diabetes mellitus, but I think it is an important topic which you should know. Many of the people, there are 2 types of diabetes in pregnancy. Either the patient had diabetes, knew about it, or the patient had diabetes, did not know about it, and then she became pregnant. Right? This is called pre-gestational diabetes. Or the patient did not have diabetes and developed diabetes during pregnancy, which is called gestational diabetes. Okay? So how do you diagnose all these? Previously, how do you diagnose all these is, see, there are 3 the criteria for diagnosis. I told you 100 is normal for a normal patient, for a normal male patient, or a non-pregnant patient. 100 milligram fasting is 100 is normal. 2 hours 140 is normal. Right? In the case of gestational diabetes mellitus, you during 24 to 28 weeks, between 24 to 28 weeks of pregnancy, an oral glucose tolerance test is done. Most of the patients, I think nowadays gynecologists do it for all the patients, because 90% of the patients do have some family history of diabetes, and even then they do it. Okay? So they do an OGTT. The slightly different OGTT is done in case of gestational diabetes mellitus. In that case, that you take a fasting glucose sample, then you take what do you say? You take a 1 hour, you give the patient 75 grams glucose to drink. Then you take a glucose sample, 1 hour glucose sample, and then you take a 2 hour glucose sample. So you take 3 glucose samples in these, right? And the diagnosis, for the diagnosis, the values is fasting is 92, 1 hour glucose is 180. I'm sorry, I have not made the slide for this. 1 hour glucose is 180 milligram per dl. 2 hour glucose is 153 milligram per dl. These are the three values you should remember: 92, 180, 153. Patient has got a blood glucose greater than 92 milligram per dl fasting. It's called a gestational diabetes. Okay? 2 hour glucose, any of one of these values is high, it's called a gestational diabetes, right? Now, if the patient, if you take a fasting plasma glucose and the patient glucose comes out to be 126, 130, that means it is more than the diabetic, non-pregnant diabetic value. Then the patient is called an overt diabetes of pregnancy. That means the patient had diabetes before she became pregnant. Okay, so 126 से ऊपर चला गया, so it is an overt diabetes of pregnancy. If it is more than 92 to 125, then the patient is called a gestational diabetes. Similarly, 2-hour OGTT value 180, 200 is for diabetes, and for this gestation is 153. The value is 153. So if the patient has got more than 153, the patient is called a gestational diabetes mellitus, and the patient, if it got more than 200 2-hour value, then the patient is called an overt diabetes in pregnancy. Okay. Patients, well, these, if the patient has got a pre-gestational diabetes, that means the patient previously had diabetes, so there is more risk of the patient, of the child being born stillborn. Certain congenital anomalies can occur in the child. If the patient has got gestational diabetes mellitus and is untreated, the patient can have a large baby, macrosomia, and the baby can develop diabetes later in life. So it has to be, we have to control this diabetes. Two other things, small things I want to point out. There is something which is called monogenic forms of diabetes. In that, the most important type of diabetes is MODY. MODY is maturity onset diabetes of the young. This is a type 2 diabetes occurring in younger patients. I discussed this. There is type 2 diabetes can occur in younger patients. And this is called a maturity onset diabetes of the young. It has a superficial resemblance to type 2 but occurs in younger patients. Then there is latent autoimmune diabetes of adults. This is an autoimmune form of diabetes that occurs in the older patients. So this is not in the monogenic forms of diabetes, but this is a type of diabetes which occurs. It is an autoimmune diabetes which occurs in the older patients. Okay? So this is LADA, latent autoimmune diabetes of adults. The clinical features and the complications of diabetes we will be doing in the next lecture. This is all for